This interesting webinar tonight. We have our speaker, Dr. Michel Kalmayer. He's a consultant vascular and endovascular surgery in the University Hospital of Munich in Germany. And he will talk about fenestrated EVAR and where the EVAR stops and the FEVAR begins. So this will be, I'm sure, a very interesting subject. We have also our panelists, a very elite group. We have Dr. Ali Badra, consultant vascular and endovascular surgery in Brest University, France. We have Dr. Wael Tawfiq, consultant vascular and endovascular surgeon in Galway Hospital, Ireland. And we have our dear friend, Dr. Samer Qusayr, consultant vascular and endovascular in the King Faisal Specialized Hospital in Riyadh. So we will start our talk with Dr. Michel Kalmayer. Then we'll have some comments from the panel, and then we can accept any questions from the audience. Please, you can use the questions and answers Q&A just to write your questions, and I'll be the one to deliver this. Dr. Michel, the mic is yours. Please share your slides.
Hello and good evening. My name is Michael Kalmayer. Salam alaikum. Guten Abend. And many thanks to Professor Salah, the chairman of this meeting, for the kind introduction, and to the colleague panelists for the invitation to this webinar. I'm very honored. I do not have any conflicts of interest. I think we all can imagine that this picture that I would like to show you from the start is not a very good patient or anatomy for a standard EVAR. And we want to talk about where EVAR ends and the fenestrated devices begin. And therefore, we have some challenges ahead if we want to plan EVARs or FEVARs. I would like to talk a little about the definition and indication for EVARs or for FEVAR. I would like to show you some guidelines, mainly from the European Vascular Society from last year, 2019. I'll show you some slides on planning of FEVARs, and I'll just talk a little about the perioperative management, how we do it in Munich. Then I'm going to show you some technical challenging anatomies, and at the end I'd like to show you just some pictures or slides on physician-made fenestrated EVARs. So to begin, the instruction for use for standard EVARs hasn't changed greatly in the last 10 years. And this table on the right-hand side is from the guidelines from last year and just on some devices or main devices used. And we still have neck lengths of at least 10 millimeters that are required for a standard EVAR. This is some numbers. Paper from 2006, quite old, but it's still true, from the Eurostar data registry. And what it shows is the influence of infrarenal neck length on the outcome after standard EVARs. And it was 3,500 patients, and they showed that in the end, the neck lengths smaller than 15 millimeters was a high risk factor for endoleaks. And meta-analysis from 2013 compared the infrarenal neck, which was inside the IFU, and those who were not in the IFU. And from 1,500 or over 1,500 procedures, 45% were not in the IFU, where they were performed outside the IFU, which is very, very high number. So it's more or less, it's beginning to get a standard to perform EVARs in or outside of the IFU. And what they could show is that the 30-day morbidity was increased in necks outside the IFU by similar type 1 endoleaks and reintervention rates. But outside IFU patients at 1 year had a four-fold risk of type 1 endoleaks and a 9 times as many AAA related deaths. Therefore, it is the crucial point about EVAR seems to be, or one crucial point seems to be the neck, the infrarenal neck. And why is that so? Because the adequate sealing zone is required to prevent type 1 endoleaks and graft migration. So let me come to the juxtarenal abdominal aneurysm. And here we have the definition of the guideline from last year, and it's extending aneurysm up to the renal arteries, which necessitates a suprarenal aortic clamping if you perform the open surgery, or on the other hand, which necessitates a fenestrated EVAR. I'll just show you some guideline recommendations and the level of evidence to it, and just to have a thought about the thresholds for fenestrated EVARs it's 5.5 centimeters, and it is recommended to perform these procedures, FEVAR procedures, in centralized, specialized high-volume centers who can perform open and endovascular surgery. So when do we do the FEVAR, or when should we do the open surgery? We have a meta-analysis of last year, which didn't go into the guidelines, and it analyzed nearly 3,000 patients in 27 studies, and it more or less it showed that that there's no significant difference between the 30-day mortality rate between FEVAR and open surgery, but there is a significant difference in postoperative renal insufficiency and major early outcome complications. And the late reintervention rates, of course, is higher in FEVAR than in open surgery patients. The guidelines, therefore, with all the other data, have this class 2A recommendation that endovascular repair with fenestrated stent grafts should be considered the preferred treatment option. Now you can think of other ways to treat patients, not having to order a fenestrated graft, which takes a long time and which is expensive, and it's maybe not even possible to get the FEVAR devices everywhere. So why don't do the chimney graft EVAR procedure? And there's one meta-analysis which shows from 2016 with 1,700 FEVAR patients versus 750 chimney graft EVARs. But be careful, there were 13 of the chimney graft EVARs, 13% were symptomatic and even 7% were ruptured. So that has to be considered if we see the outcomes. And in the end, we had a support for the FEVAR, which in terms of 30-day mortality and target vessel occlusion, and in type 1 endoleaks. And on the other hand, we had a support for the chimney graft procedure in technical success, type 2 endoleaks, and of course in type 3 endoleaks. Nevertheless, the guidelines recommend that parallel grafts, chimney graft EVARs, may be considered as an alternative in the emergency setting if we have to do something. Now to come to the planning of a fenestrated EVAR graft. We have a lot of recommendations, requirements for the anatomy. We have to consider the angulation of the suprarenal aorta and the infrarenal aorta. We have to have the diameter, the infrarenal diameter of the aorta not extending something around 30 millimeters. And we have always to consider the access through the groin, the femoral artery, and the iliacs, which makes the planning difficult. And I'll show you some cases in a couple of minutes concerning these thresholds. This is a planning sketch from a patient. We implanted a FEVAR. This is how these planning sketches look like. These sketches are taken from thin slice CT angiograms, 0.3 millimeter slices regularly. And then there's the fenestrations are planned, the sizes of the fenestrations and how they are aligned with the vessels of the individual patient. And then these devices are hand manufactured, and that takes a long time. We are still waiting for devices around 8 to 10 weeks. Now, this would be a sketch of a Terumo aortic anaconda prosthesis. And what is nice about this prosthesis, they offer a prototype. And they have this printed aortas, which they print from the anatomy of the specific patient, and then they'll implant the graft, which you will have in the end, and they'll show you that the fenestrations are just aligning with the individual renal arteries, mesenterics, and celiac arteries. The planning or the perioperative planning is one crucial point to the whole procedure. And just to share some thoughts with you that we have with every single patient, we evaluate every patient on the endovascular and on the open surgery, just in case that if you have to convert. And we always evaluate the cardiac situation with an echocardiogram. And we always want to have at least a non-invasive myocardial evaluation by MRI or a scintigraphy. And then we, of course, evaluate the renal situation, filtration rate, creatinine. And then we have to consider, are there any accessory renal arteries, or are there only the two main renal left and right renal arteries? And if we have more than one renal artery for one organ, for one kidney, then in cases we do the scintigraphy of the kidney, just to make sure how much of the kidney is perfused by each of the renal arteries. The perioperative management in terms of antiplatelet therapy is we always have patients on at least aspirin, and intraoperative we change to heparin, and we control that with the anti-ACT control, active clotting time. And postoperatively, we go on to aspirin and clopidogrel for the bridging stents and in the organs, so that we don't have any problems, and we'll keep the double antiplatelet therapy for at least 6 weeks. And then we'll go down to aspirin again. For the prevention of spinal cord ischemia, we, depending on the extent of the endograft, how far we go into the thoracal part of the aorta, and we consider spinal cord or the spinal catheter, and we always have in mind the collaterals coming from the iliacs, for example, just to be sure that there's no spinal cord perfusion problem. Intraoperatively, we'll always want to have a more hypertensed patient for the perfusion of the collaterals, and the hemoglobin level should be always above 10 grams per deciliter. The whole procedure is only good if there's a good follow-up, because we know that these patients, they can develop problems in the course of time. And there is a class 1 recommendation that there should be a thorough long-term follow-up program. And what we do is we check all patients post-operatively with contrast-enhanced ultrasound and by CT angiograms. And at 4 weeks after discharge, we do another contrast-enhanced ultrasound. At 6 months, we do a SOIS and a CTA, and then we go to annual checkups. But this is a crucial point for good results, good outcomes in long term. So now I'd like to share with you some technical challenging patients. We performed the endovascular procedures in the last years. Some of them were not as successful, to be honest, as we had hoped initially, but I think that's important to share not only successful procedures. So this is a male patient, 78 years old, and we planned a fenestrated EVAR due to this juxtarenal aneurysm you can see on the left-hand side. But then what you can see as well is the atherosclerosis in the iliacs, in the access paths to the aneurysm. And therefore, we had to do a conduit procedure in this patient. With a conduit onto the external iliac artery, and then we did the procedure, and everything just went fine. And we did the fenestrated fenestrations to the both kidneys, and we had everything went fine. And then we, in the end, we took the conduit to a bypass. So we actually bypassed this more or less occluded external iliac artery. And now, why am I telling you this more or less old-fashioned open access technique? I brought another patient with me. Colleagues performed this patient with a juxtarenal aortic aneurysm, and we planned a 4 times fenestrated FEVAR for this patient. And this patient had this stenosis of the right common iliac. And this was the right side was the better side. So it was no option to have the device brought up by the left-hand side. So what we had to do, or what the colleagues did first, is they did a stent PTA in the distal common iliac artery with a steel stent 10 millimeters wide, which should be far enough to have a good access for the 22 or 24 French devices of the FEVAR. In the end, this FEVAR was not possible to proceed the FEVAR into the position infrarenal or pararenal, and so we had to give up the thought of doing the fenestrated procedure, and we thought about just excluding the lower part of the aortic pathology. And the plan was to do that with a monoiliac Medtronic device. The device went up; it went through the stent, which was implanted in the iliac. But what happened is the stent came up with the device, and in the end, the stent was like a belt around the device. This is just to show you that small problems can exceed to a very major problem. And in the end, this patient had to be converted while this procedure. So it's the small things we have to think about while planning this procedure. And if it has to be a conduit, a hybrid OR procedure, then do the hybrid, do the conduit. Another challenge is the kinking of the aorta, which we observe frequently in patients with juxtarenal AAAs. And this is just to show you how we plan these procedures. If we just take the normal CT scan and if we measure the distance between the renal arteries, it would be something around 18 millimeters in this case. If we do the perpendicular measurement by the center line, as we should do for this patient, then we reduce the distance between those arteries to 3 millimeters. But what we have to keep in mind is that the anatomy changes quite rapidly as soon as we introduce the stiff grafts. The stiff wire and the 22 or 24 French devices, they straighten up the whole anatomy of the aorta. And this again changes the position of the arteries or the fenestrations to the arteries. And therefore it is good to plan these fenestrated endografts in advance, considering this movement of the aorta, the straightening of the aorta, and where exactly we should position the fenestrations into the graft. And for this patient, where we assumed that we would have some complications in this kinking, we planned the fenestration in the lower part of the stent graft so that there would be no movement. And you can see the stent beneath the left fenestration, which is crimping into the aorta. That would have been a big problem if we had planned the fenestration below the stent grafts. Again, another patient challenging anatomies could be very steep arteries descending from the aorta. This is a patient, 71 years old, who was planned for 2 times fenestrated and once for the renals and a scallop for the mesenteric artery. And meanwhile, we have good devices with steerable sheaths, guiding sheaths. What we use mainly is Oscor or Medtronic steerable sheaths. This has made access to difficult anatomies or difficult arteries easier. Nevertheless, there are still anatomies where we don't have, or where we have to have other options in case if we cannot cannulate the arteries. And this is a female patient, 69 years old. She was planned for a double fenestrated device and a scallop. And what you can see in this second slide already is that the fenestration on the left-hand side to the left renal artery, this is a Jotec device, was somehow screwed up. And that's what we could show that in the angiography, and we had very big problems to introduce the wire through the fenestration into the left renal artery. The right side was no problem, but the device was somehow not there where we wanted it to be or expected it to be. And the main reason was probably that the whole device was, when brought up through the iliacs, was twisted, and therefore the fenestration was not there where it should have been, and the whole device was not positioned, or we couldn't position it where we actually should have, or where we would have wanted it to be. In the end, there are a couple of possibilities to cannulate a fenestration like that with a normal guiding catheter, or with a Oscor sheath, for example, or you can, in this case, this is with the tip capture, or with the tip captured, you can still try to use the roof of the prosthesis of the graft to get your wire through this window. And if that all that doesn't work, you can put a big balloon into the tip of your device. Maybe you're lucky and you can get the wire through the window. What Gustavo Oderich showed in a very nice paper is another technique. If you have the problem with misaligned fenestrations, that you can bring a balloon from the outside of the graft, between the graft and the aortic wall, and then maybe you have the chance to bring to have more room between the graft and the aorta, and to cannulate the renal artery, for example. All this, to be honest, was not possible in this patient, and in the end we had to perform a bypass procedure to the left renal artery, from the external iliac to the renal artery, as emergency, to have the perfusion to this organ. So it's not always easy, and sometimes it's you have to leave the way, or the endovascular treatment, and you have to go back to the open surgery. This is a patient, a male patient, 82 years old, with a very complex renal artery situation on the left-hand side. I brought this CT scan, and you can see there's the main renal artery is splitting into two very shortly after the descending of the renal artery. So in this case, we initially planned a non-standard device request, and just to show you what is possible. And with Cook, we planned this patient for a double bridging stent into these big main renal arteries. And that was very successful, no endoleaks, no problems. And here you can see on the right-hand side the CT scan with the two bridging stents in place. I was asked by the panelists yesterday in preparation for this talk whether we are performing inner branches. And this is a quite new development in endovascular treatment of juxta or thoracoabdominal aneurysms. There are, it is more or less, again, we have these custom-made devices, and it takes 6 weeks to get these devices. And we have these planning sketches, and on the lower planning sketch, you can see those small snorkel-like inner branches. It's branches that are knitted or sewn to the device. You can have them for an access from the arm, like in this case for the celiac and the mesenteric artery coming from from cranial, from the arm access, and for the right and left, for the left and the mesenteric coming from the groin. And this is how these balloons are in the inner branches then, and this is a quite busy slide, but more or less the finished procedure. This is another case with a thoracoabdominal aneurysm type 3. And what we did here is a inner branch prosthesis again, or a graft with all branches, inner branches coming from the arm access. And this is how this patient or the angiography was at the end of this patient. So this inner branch procedure, or the grafts with inner branches, is a quite unique technique, and we are looking forward to having access to the Cook device. These devices I just showed you in these two cases are Jotec devices, but there's a big potential in this technique. But what should we do if we have emergency cases? Not every patient is elective, and we can plan every patient for in advance, for months in advance. And we have anatomic constraints. We have issues with high prices for the FEVAR devices, the long manufacturing period, and what do we do if we have an emergency setting? And there we still have one last option in the endovascular technique if the patient is not a candidate for open surgery, for example, and that is the physician-made EVARs. And here again, and this is just the last guideline recommendation I want to show you, and it shows, or it says, it's a to be recommendation with a may be considered that in patients with ruptures, abdominal aortic aneurysm open repair or endovascular repair may be considered. It's both same weighted. And there you can consider the physician-made fenestrated grafts. And I just want to show you some slides how we perform these procedures. This is a normal SINIT alpha Cook EVAR, which is opened just to the extent where we want to have the fenestrations, or the scallop, in this case 2 fenestrations, 1 scallop, and we burn these windows or fenestrations into the graft material. Then we align the fenestrations, in this case with a wire of a snare catheter. It's a very radiopaque golden wire, which you can see very well in the end. And then we take the radiopaque segments of a measuring catheter. We sew all this to the grafts, creating fenestrations. This would be the graft as it looks after the fenestrations have been applied, and then we maybe you can see these stents are sewn together, so that the whole graft is more maneuverable in the aorta as soon as it is in the aorta, infrarenal aorta. Here's the picture where you can see the 2 fenestrations. The contralateral leg of the prosthesis is opened already. This is how we repack the prosthesis into the graft before we implant it, and that is how we implant the bridging stents via the open contralateral iliac branch. Another case is this of a lady who was initially operated by the visceral surgeons, a female patient from the Arabian Emirates, actually, with a pancreatic tumor, who underwent a Whipple procedure. And she had an erosion of the celiac trunk, which was needed open reconstruction, and in the end we had to close the celiac trunk, which was very good collateralized via the mesenteric artery, and we had to patch the aorta. The patient was discharged to other hospital, a secondary care hospital, to recover, and came back in an acute bleeding situation. So after 8 or 10 weeks after the Whipple procedure, there was no way to do any open surgery to the aorta. So we performed a physician-made EVAR. This is actually a TEVAR device, a Cook TEVAR device, where which we fenestrated with 3 fenestrations, 2 for the renal arteries and 1 for the superior mesenteric artery. And this is what it looked like in the end. And this patient survived, and now she's back in the Emirates. So, dear ladies and gentlemen, I would like to conclude my talk with first, the FEVAR should be considered as first option in juxtarenal AAAs. And always, if there's a neck smaller than 10 millimeters, it surely should be considered. The planning, the perioperative management, and the follow-up in these complex endovascular procedures is crucial, and it's crucial for a good outcome. It's a big team effort with multidisciplinary approach. But that's what we need to do to have a good long-term result for the patient. And if we don't have any other option, surgeon-modified EVARs as bailout strategies are still in hand. And therefore, I would like to thank everybody. I would like to thank Professor Salah as a chair and the panelists, and I'd like to thank the audience for your attention. Shukran, and I'd like to discuss with you this talk. Thank you.
Thank you very much, Dr. Kalmayer. It was really a very interesting talk, and you brought up many tips and tricks for difficult situations. And I'm sure that especially those who are working with FEVAR, they appreciate much these tips and tricks. I will start by having a comment from Dr. Ali Badra, our panelist. Dr. Ali, if you have a comment or question for Dr. Kalmayer.
Thank you, Dr. Michel, for excellent review for fenestrated and branched. I have some question. In France, especially in our center, the situation is a little bit different for juxtarenal. If you have juxtarenal aneurysm and patient fit for surgery, you do fenestrated or you do open surgery based on your meta-analysis for results of fenestrated graft. First question.
Thank you for the question. Actually, we evaluate every patient individually, and it depends on many small things, on the age of the patient, on the comorbidities. What this meta-analysis is showing is that there is a endo-first tendency at the moment, and for old patients, for multi or with many comorbidities, I think fenestrated EVARs are a very, very good option, and we are. I think it depends on how your outcomes are, and if you are in a specialized center, and if you have the experience with this technique, then the FEVAR should be offered to the patient. Yes.
I don't agree totally your opinion. If a patient in my age 57 and I have an aneurysm, juxtarenal aneurysm, I prefer to do open surgery and not fenestrated graft. You have more 10%, 15% of reintervention, complication of side branch, and all problem of fenestrated. We reserve fenestrated graft for high risk surgery in our center, maybe.
You are right, and you are a young man, if I may say so. But we are treating patients 75, 80 years old, and therefore the recovery of a open surgery is not that good in that age anymore. And we don't have very much data for FEVAR or for open, or we don't have any randomized studies, of course not. But we are lacking evidence, and the little evidence what we have shows that there is no big difference for the older patients, and therefore the recommendations, yes.
Okay.
But for young patients, I agree totally with you, yes.
Okay. Do you use the fusion technique? I do also fenestrated for patient. Do you use fusion technique for your intervention or no, to do procedure and fenestrated?
For the to show the fenestration or the organ
Okay.
in the hybrid, or I'm not quite sure if I know what you mean.
You don't present fusion technique to help
fusion imaging, yes.
Fusion imaging.
Yes.
You do
Yes, we do
and
that.
SFA drainage, if you have type 3 or 4, you do it before surgery or after surgery. CSF drainage of liquid for type 3 and type 4 aneurysm. You do the drainage of SFA before or after a procedure. If you have sign, neurologic sign, or before, you don't wait.
No, we actually do. Both you're talking about the spinal cord.
Yes, spinal cord drainage.
Yes, we actually do that before the procedure.
Before,
mainly before.
Like us, yes, yes.
Yes, I think it's if you have to do it in as an emergency, the spinal cord catheterization, then you have you'll have big problems.
Okay.
And because we monitor the pressure via this catheter during the whole procedure, therefore if we think there could be problems ahead, then we do that beforehand.
Okay.
A day before the procedure.
Thank you.
Okay. Thank you, Dr. Ali, for this comment. I'm sure there is some points you cannot have a universal agreement about this, but it's very nice for discussion, you know. We can have a comment or question from Dr. Wael Tawfiq.
Well, I was probably going to start off by the exact same comment of Dr. Ali Badra about kind of FEVAR versus open. And there is an ever so slight conflict between the ESVS guidelines and the NICE guidelines when it comes to that, in that the NICE guidelines are recommended that complex EVARs, including FEVARs, should only be done within an RCT kind of setup, a randomized controlled trial setup. Now, I fully understand, and kind of they are done outside of RCT, but there's never going to be a full consensus, at least not for now. So it was just kind of a comment. My question really was, so the title of your presentation was, where does EVAR end and where does FEVAR start? And I would probably ask that question when it comes to ruptures. Where does EVAR or even CHEVAR end in ruptures, and where does physician-modified FEVAR start when it comes to emergencies?
Yes, thank you, Dr. Tawfiq. It's the modified devices to modify the device takes something around 1.5 hours, 2 hours. So it's not it's no option for an unstable patient. And for an unstable patient, it's always an option to the open surgery again, or the chimneys, actually, because if you have a symptomatic patient and you can plan the modifications, or as in the case I showed you, this lady who was not open ruptured, but she was bleeding already, and you have the time for a modification of a device, then you can think about that. Yes, but it's no option if you have very a high emergency patient.
If I may, just one quick question. Again, regarding the spinal cord ischemia. If you happen to have a patient who has internal iliac involvement as well, would you opt to do iliac branching, as in you add to the time of your procedure in order to preserve the internal iliac, just for the sake of minimizing spinal cord ischemia? Or would you just sacrifice it and do your spinal drainage and forget about it?
We would actually do both. First, we would maybe even in a staged procedure, we would recanalize the internals, iliacs, maybe even with a bypass if needed, and then maybe in a second procedure we would do the fenestrated procedure, and then again with the spinal cord catheter. So we are always trying to have a backup for any events that might come. But the internal iliac arteries they're crucial for the spinal cord perfusion. Yes.
Thank you.
Thank you very much, Dr. Tawfiq, for this comments and enriching the discussion. And then we come to Dr. Samer Qusayr. Dr. Samer, if you have any comment or a question for Dr. Kalmayer.
Okay, thank you, Michael, for the presentation. It was really excellent and very enriching and very nice tips, and tricks. First of all, I'd like to just add my voice to Wael and Ali that good fit patient has to go for surgery. No questions, the patient fit for surgery, because, you showed, by your own data that the mortality is 30 days, even long-term mortality is no different, So we know FEVAR in the long run, a lot of problem with the branches, fracture, dislocations, renal artery occlusion. So we know that they are a problem. Whereas the open, they are more durable. So I think this patient fit for surgery. I still think my first option will be an open repair. The second thing for a spinal drainage, what Dr. Ali talked about, to do it before or after the procedure. There's a big study which showed that it's no different really if you do it before or right after the procedure if needed, So some people they do prophylactic, some people they wait until patient wake up if he has any symptoms, then he can do it, and then it's no different in the neurological outcome. Because also some people they think that spinal drainage has its own complication like bleeding hematoma, which can cause a problem. So I think, of course, it's better always to do it before, but for some reason if you cannot, you can do it after, but you have to be ready to do it right after. You cannot like wait after and nobody there around, then be a problems, This is my main comments, The second thing is that
maybe just excuse me, Dr. Kassan. Let me have a chance to comment on your comments. First, yes, you are with the open surgery. I was asked to give a talk on fenestrated procedures. So and as we are doing them quite frequently, I just took the part pro fenestration. But you are very right. Open surgery should be for younger patients, for patients who have who are no high risk for open surgery, should be the first option. Of course, that's absolutely true. To your second comment about the spinal cord ischemia and the catheter, yes, you are again there is this data. But what we are missing is we can only see the effect on the spinal cord on patients without a catheter after the procedure, when they are awake again. And we are missing the whole time of the procedure, which can take 4, 5, 6 hours. And meanwhile, with the catheter, we can measure the pressure and we can see that there are problems coming up. And we can lower the pressure actively. So I think we like to have the catheter in advance so that we don't have to get into an emergency situation which we could have foreseen.
Okay. The second question, do you think the outcome is different between 2 fenestration or more? Like if you do 2 or 3 or 4, is the outcome is different or the same? Like if you do both only 2 renal, or you have to do like all celiac and SMA, is the outcome is the same or is different?
The more fenestrations you need, the more complex the whole procedure will be, and the planning and the alignment of the fenestrations to the vessels in the end, and the more problems you can have with dissections of vessels, etc. So I think with the more fenestrations you have to manage, the higher the risk.
Okay. Sorry, I'm giving you a lot of questions, you know.
Thank you for the questions.
No problem. The second question, I mean, if you have an emergency, you said you do a custom made, you know, and we know that custom made is, we don't have data to support it. This is your device, which is you go and burn it, you know. We don't know how much damage will be to the fabric, you know, where you have other options to go with a chimney, which is a very stable technique. We have a data to support it. We know it's an good outcome with the chimneys. So, and especially now the new device become low profile, so the fabric become thinner and thinner now. So I don't know how much damage this, you know, custom made fenestration will make to the device. So I think in emergency, I still think maybe chimneys will be at least more supportive with the data than custom made. Do you agree on that, or you still think we should always go with a custom made?
Partially again. Your comments are absolutely right. You can burn the whole graft like a fire, if you're not careful. And again, the physician modified devices are just an add-on if you don't have any other options, or if you have the option of modified devices. And what you don't have the gutter problem for endoleaks, for example. And it's, of course, this is something out of IFU, and this is nothing where we have any randomized data on, and it's this is very specific. I just wanted to show you a next option for individual devices in situations where you maybe don't have the option for chimneys. That's possible as well. If you don't have subclavian, or if you have subclavian occlusions and thinking about access, there's always patients who may be not good candidates for chimneys.
I think I'll give a time for the attendee to ask question, and then I come back if still more time. Go ahead, Mahmoud.
Well, if you still have questions, you can go on. We still have, we don't have much questions from the audience. So if you have another question, don't be shy, come shoot.
Okay. All right, I'm saying when this case where you have a alignment of the renal arteries, and you open it and you did a bypass, you did debranching. Have you any experience to do retrograde cannulation and of the renal artery to go retrograde after you open a retrograde, and maybe it's much easier than bypass?
I didn't understand this question. Excuse
me. You show us a case where you miss the renal artery, so you have to go and do bypass the renal artery.
Yes.
I mean, when you open the belly, is other technique to go and cannulate the renal artery retrograde and go back and fenestrate the graft and do retrograde fenestration. Do you think this is an easier technique, or the things, because sometimes bypass renal could be difficult, especially if you have juxtarenal huge aneurysms?
Absolutely, but in this case, that was not the retrograde was no option, because we knew from the angiogram that the fenestration wasn't where it should be, and we would have had problems in advance. So the safer technique was the bypass technique in this case, because if you have a crumbled fenestration and you have to bring a bridging stent through that, then the outcome probably will not be good.
For the cover stent, I mean, you have like a couple of, balloon expandable cover stent, which I think what you use. What's your favorite? Is any like thing you favor, like, is any special or outcome? Does it change with changing that kind of cover stent? Or do you use self-expandable stent?
We have experienced some problems with some devices, yes. At the moment, the Gore VIA-BAN or VBX is, in my opinion, probably the most durable and the best to handle. It's very flexible. They have high radial force. They are quite expensive in Germany, actually. Our main device for bridging stent grafts is the Advanta, which is again, it's not as flexible as the VIA-BAN or the VBX from Gore, but it's a very good stent graft. We experienced some late dislocations or endoleaks through the fenestration with, for example, Livestream from BAT, which seems to have less radial force, and during the time seems to sometimes develop endoleaks, which we didn't see in the beginning without the whole graft being migrated. And maybe as last, I think Jotec Eventus graft, which is a graft, or the original one, I think they're planning, or they have changed it already, I'm not quite sure, was that the grafting was only on the outside of the stents. And what we had problems with, we dislocated a stent graft during the procedure when you implant the bridging stent, and then you want to go back into the bridging stent to flare it in the window, in the fenestration. We shoved the whole endograft into a in this case it was a mesenteric artery, because the tip of the balloon got hung up with the stents inside, because there's no inner covering, and the whole stent graft was shoved into the vessel. That's my experience with bridging stents and complications with bridging stents. So at the moment, I think my first choice would be the Gore VBX.
Do you add any self-expandable stent distally? Because some people, they do it to ease up the stiffness of the balloon expandable stent. Or you think this is an extra, doesn't work?
Excuse me?
Some people, they put self-expandable stent and cover stent distally,
yes,
to and ease the curve. You think this is help, yes, or is more complication?
No, it's. I think if that's what we don't usually do it, but we do it in case of if we see a kinking at the exit of the bridging stent, then we implant self-expanding nitinol stents to just to not give it any chance that there's a secondary kinking. Yes.
Thank you very much.
Keep up the frequency. Yes.
Thank you very much for this series of comments and questions. I guess we agreed about one point, that when you have a fit young man with para-renal or juxta-renal or something that you cannot do EVAR and you needed to choose between FEVAR and open surgery, if the patient is young and fit, I guess open surgery is there and will be still there. Of course, the answer of this question will differ if you are working in a high volume FEVAR patients or you are not doing a lot of FEVAR. If you are not doing a lot of FEVAR, of course, open surgery will be the first option to jump into your mind. If you are doing FEVAR in a high volume, maybe this FEVAR will be your first option. But as a general rule, we all agreed that open surgery is having a very good rule. And I'm sure Ali Badra, because I know in France, this question even comes to the EVAR. If the patient is young and fit, and you do open surgery or EVAR, so how about FEVAR? Dr. Al-Badra can comment about this.
Yes, I agree with you, totally agree with you. Concerning the bypass of the renal artery for Samer, my friend Stéphane Hollande presented in IMED in Nice a solution for a dislocation of the stent into the fenestration. He punctured the renal artery, left renal artery through the lumbar, the skin, and he snared the wire, and he continue to put another stent into the renal artery.
This is Stefan, you know?
Yes.
Exactly.
Not me or you, I'm sure.
Okay, Dr. Tawfiq, you have any other comment before, because we are approaching to our end of the session?
Fair enough. Okay. No, I'll just a very quick question regarding the double renal, where you put a double barrel stent into. Would flaring be enough with the two stents going through to avoid guttering, or would you have to do anything further than that just to avoid guttering?
In this case, flaring was enough because the fenestration, and we had enough graft around the vessel ostium to seal it, to seal the fenestration, and we had some space to the aneurysm, aortic aneurysm. So in this case, the flaring was enough. We didn't do any glue or coiling or extra procedure. Yes.
Dr. Kellmeyer, you
Okay.
you try a laser fenestration or not in emergency case?
Not yet. No. No. We have heard about that, and we are following that with big interest. There's a big development. Stéphane Hollande and I think published a case or a series on that, and Gustavo Odrich,
Yes.
they have the peak of this.
Dominic Faber, I last October I do 2 cases with Stéphane Hollande, and
Okay.
Excellent technique.
Okay. Maybe I have to come to Brest, and maybe you have to show us this technique. Yes, because that's seems to be another step. But I wasn't quite sure if you flare the bridging stent in a lasered fenestration, is the fabric durable enough, or don't you do any flaring?
You must flare with the laser. You flare the fabric, and you do a balloon with a coating balloon first.
Yes.
And after the coating balloon, you do the first stent, and you flare the stent like fenestrated, like usually your fenestration.
And you don't experience.
We don't know. We haven't a big experience and big follow-up for this technique.
Yes.
Stéphane and Dominic Faber has a colleague. You have 100 cases now. 100 cases.
Yes, that's a very, very interesting technique. Yes.
Yes.
Okay, finally, I would like to thank Dr. Michel Kalmayer for this very nice, interesting talk, for the very nice tips and tricks. And I'd like to thank Dr. Ali Badra, Dr. Samer Qusayr, and Dr. Wa'il Tawfiq. And of course, we thank Mr. Shobet, our dynamo, arranging these webinars, and we thank the Saudi German Hospitals Group for arranging this, and hopefully we can meet again for another interesting subject. Thank you very much. Thank you for all of you.
Thank you, Mahmoud. Thank you.
Thank
Thank
you.
you, Michael.
Thank you.
Appreciate it.
Thank
Thanks,
you.
Ali.
Thank you very much.
Bye. Take care, guys. Take
Thank
care.
you.
See you.
Bye-bye.
Bye-bye.